Thank you very much, Pisana, and I would like to thank the ESC and the course organizer for inviting me. I'm talking on behalf of the industry that mainly is Actelion and my colleague from Bayer, where we discuss my presentation. And my first comment to the guidelines is that is really an impressive piece of work. I think that since the guidelines started to be in PH, they have helped us a lot in conducting clinical studies. They are really focusing from classification to diagnosis, to clinical characteristic, to therapy. They evaluate specific PH subset. And they are also touching not only PIH, but also the other form of PH. And we, as a companies, we are interested not only in PIH, but also we do studies in the PH field. So it's very important to have a clear classification and a clear disease definition. And there is also, I have to say, an impressive collection of reference. When I look at the guidance and I see that there are more than 450 references, it really kind of is really showing how much work has been done. And I think, you know, as an overall comment, is a really fair representation of the situation today in PAH. Having said that, I would like to focus my presentation on 4 points. One is risk assessment. The second is the evaluation of the clinical trials and the therapies. The third point is the disease definition. And the fourth is the endpoint definition. And I will start with the risk assessment. I know that you have seen this table almost in all the presentation, but I would like still to talk about this. I think that is a very clear table, is a very good evolution from the previous table where there was this gray zone. Now patients are really categorized into 3 very clear categories. And that, you know, is also very clear that you need to use multiple parameters to assess the patient. But I have also, and we have also as a company, some questions. The first is the table applicable to all the patient? Meaning, is a patient that is newly diagnosed and is in the green zone, for example, is similar to a patient that is on triple combination therapy and it is in the green zone? Can we treat these 2 patients as the same? Or if you have a patient that is in the yellow zone on 1 drug or on 2 drugs, how we should differentiate this? And the third question that is also very important is, we know that life is not black and white and is not green, yellow, or red. What about the patient in between? And on this aspect, I have to say that is not sometimes very clear how and when to utilize the table. And I think that it's also not easy to then evaluate what to do with the patient in between. I have to say that I'm using the same patient that Simon presented yesterday. And I think, you know, what to do with patients that they are a little bit in the green and a little bit in the yellow, you know. And I think that one way to clarify this would be to have patient cases in the online supplementary material for the guidelines, and to kind of to explain to physician how to deal with this patient, because sometimes it's not easy. And also, if a patient has this risk profile and he is newly diagnosed, maybe you have a treatment pattern that is different from a patient that is in the same risk profile, but already with 2 therapies or with 3 therapies. Are they going to list for transplantation or not? I think that to have examples in the supplementary material will help a lot the treating physicians. What about evaluation of clinical trials and therapy? And this, of course, this is the section of the guideline that we look very carefully, and we look at each comma and at each word because it's very important for the companies. The first point that I would like to touch is the level of evidence. And I have on purpose decided to use as examples only Actelion drugs, so make sure that I don't make an unfair comment to other therapies. If we look at bosentan, bosentan has 3 trials in PH, 351, BREATHE-1, and early. Duration between 12 to 24 weeks. The primary endpoint in all the 3 studies have been 6-minute walking distance. Only in early we had a co-primary endpoint of PVR and 6-minute walking distance. And in total, in these 3 studies, we have enrolled 430 patients. With macitentan, we have only one trial in PH, with a median duration of 115 weeks, with a primary endpoint that was a composite of morbidity and mortality, with all the events evaluated by an independent event committee, and we enrolled 742 patients. But when it goes to the level of evidence that is clearly defined in the guidelines, bosentan as a A and macitentan as a B. And I think that every time we put A and B, it clearly gives the suggestion and the impression that bosentan is a better therapy than macitentan, or at least have more evidence than macitentan. Of course, if you carefully read the paragraph, it is very clearly written that in the absence of head-to-head study, no first-line therapy can be proposed. But what is coming out from the table is a kind of a better evaluation for a drug that is 15 years older, but that have more studies compared to a drug that is new with only one study. And I think this is applicable not only to the two drugs that I mentioned, but there are many examples in the guidelines. There is also another aspect of the evaluation of therapy. Again, let's take macitentan as an example. If you use macitentan in monotherapy, the level of recommendation is 1B, but on initial combination therapy is 2AC, and in sequential combination therapy is 1B. And the B we have seen is the level of evidence, and the 1, the 2, or the 2A are the class of recommendation. So at the end of the day, the question for us as a company, and I think also for the end users, is, so which is the overall evaluation of this drug? Is a good drug 1B, or is not a good drug, is a 2AC? And I think that a better, let's say, a simplified version of the guidelines could help the treating physician, because I think, for the people that are in this audience, that they're very knowledgeable and they know and they read the guidelines, is easier to know where to place the drug. But for the end user of the guidelines, the physician that are using the pocket guidelines, it may not be so simple. And I think that it also refers to the concept of initial combination or sequential combination, guidelines driven, as Gerard is always mentioning, and I think this is a very important point, because if we look at sequential combination as it is suggested by the guidelines, you add the second drug when the treatment goals are not met, and not in case of worsening. And usually you add the second drug after 3-6 months when you evaluate the patient and the patient is not doing as well as you want. And the question is, can this delay of 3 months make a difference or not? Because what I think is very important, if we look at the study that have been done in PAH, Seraphine or Griffon, these studies, they're not true sequential combination studies, because patients that were already treated and then they were randomized to get the active drug or the placebo, they could have been on the first drug for 1 month or for 3 years. So for sure, this was not sequential combination therapy guideline driven. This is adding the second drug in many countries when you have the possibility to add the second drug. And I think, if we talk about therapies and strategies, this is also maybe applicable also to another form of PH, that is CTEPH. When we talk about, the non-acceptable risk-benefit, what about a second opinion? Do we need to just go with one opinion from a surgeon? This could be a question mark. Of course, in the treatment algorithm, the medical therapy and the BPA are considered equal, even if the level of evidence is different. And again, it's the same concept of the PH therapies, how much the level of evidence and the recommendation should drive treatment decision, or are just based on the amount of information that are available at the time when the guidelines are written. And the third question mark is, do we need a risk assessment? We have talked a lot about risk assessment in PH. I think there is also by some expert in the congenital heart disease field, the attempt to have a risk assessment also for Eisenmenger patient. The question mark, do we need a risk assessment for CTEPH or not? My third point is regarding disease definition, and disease definition is absolutely important for us. Without the classification that was done already in Evian, it would not have been possible to run clinical studies in an homogeneous population. So I think, for us as a company, disease definition and a clear disease definition is very, very important, because we do studies based on this definition, not only in the PAH field, but also in the PH field. And the example is coming from the group 2. In the group 2, there is the definition, a very specific definition for PH with left heart disease, that are patients with combined pre- and post-capillary PH with a diastolic pressure gradient of more than 7 millimeters of mercury and or the PVR more than 3 Wood unit. Based on this definition, we have run a study that is called Melody, and result will be reported next year in a scientific congress. And then the question mark is, we need to make sure that when we have definition, we also then take the result of the clinical studies to evaluate if the definition are really responding to what is happening in the patient population or not. Because, as I said, this is driving clinical trials decisions. And last but not least, the endpoint, and I was very, very pleased to have this discussion. So the endpoint are usually not part of the guidelines, but are part of the recommendation from the World Symposium on Pulmonary Hypertension. And I think if we look today, we have 4 outcome studies that have been performed in PH, is Ambition, Compass 2, Griffon, and Seraphine. 3 of these 4 studies are coming from Actelion, and we are very proud that in these 3 studies we have used 3 different primary endpoints. So we are not really kind of setting the standard here. And then in addition, the CHMP has its own definition of a morbidity mortality endpoint. And I think that in the future, what we should do is we should have a consensus meeting, putting together expert, regulatory agencies, and companies, and they would say, with the objective to come up with a definition of an endpoint that is acceptable for the regulators, acceptable for the companies, and acceptable for the treating physician. And I think that the question regarding are we going to go to first event or are we going counting events is very important. We do believe in Actelion that one of the significant issues that we are facing when we count the first event is called informative censoring. So you lose more patients in the placebo than in the treated arm, and then you have less patients in the placebo arm that are at risk of death compared to the treated arm. And this could cause an imbalance in the primary endpoint, and then it cause a problem when you go for registration. On the other end, as Nazareno and Gerald were pointing out, if you just count event, the issue is that in PH you have therapies that are considered life-saving like IV epoprostenol, and you cannot not grant this access to patients when they have a significant event like an hospitalization for PH. But I think that a consensus would be very, very important as a way forward in outcome studies in PH. And I think to go back to what also Simon Gibbs was suggesting, we may also need to share our databases and to share the knowledge that we have developed on the primary endpoint of morbidity mortality to make sure that we have an informed decision on how to progress on this matter. And with this, I would like to conclude. I think the guidelines have been a significant advance in the field of PH and a significant advance for us as a company, because they have provided the possibility with clear classification and disease definition to perform studies in homogeneous population and to go for approval. I think that now they reflect what is available in PH, and is a good reflection of the situation of the clinical studies. Of course, when you go with guidelines that are coming from ESC and ERS, so scientific society that are used to big disease area where the studies are much more homogeneous, you have always have this imbalance regarding, some definition of the evaluation of the therapies, because from what I understand, it's very clear that the ESC, they want to have this level of evidence ABC, and this maybe does not apply to rare diseases like, for example, PAH. And I would like to conclude thanking you very much.
Thank you, Alessandro.